So I have the job of kind of summarizing and wrapping up, which is not easy. I think, we had really a great workshop with terrific attendance, and somebody put up my slides. So I normally wouldn't do this kind of a talk, but I thought this was an opportunity. And where is the changer? Did somebody walk off with it? Okay, all right. Thank you very much, Aaron. So, and that reminds me, with Aaron walking up here, we have to really thank the staff because they make it happen for us. So I think it was a wonderful meeting. And I want to thank the planning committee, which was actually a very robust group of people. Some people I knew, some people I didn't know and became acquainted with. I've been on many planning committees for workshops here at the Academy, and this was about the most cantankerous, lively group, really invested. I mean, and I think you see what we got. And then I really have to thank Ron. I mean, when I was on the forum, he brought this up a couple of years. Isn't it time to revisit what's gone on, since the Lost in Transition? And just a wonderful colleague to work with on this, so thank you very much. So I'm going to just go through some historic slides because my first involvement with the Institute of Medicine was actually being on this committee where we really pointed out, and Ellen Stovall, again, in her passion for survivorship, getting the Office of Cancer Survivorship established and so forth, really wanted to see this report come to fruition so that there would be attention paid to that time to the 10 million people who were living in that yellow box out there. And the late Roger Wynn, who maybe some of you recall, he was a very eminent oncologist. He was on the committee with us, and he had this kind of aha moment. He says, I never thought about all the people and what happened to them after I treated them. And so that was really where we were 2003, 4, whenever we started our committee work, and the report came out in November of 2005. And so we had to draw this trajectory to really show that, again, at that time, we expected maybe 65% of individuals treated would land out there in the cancer-free survival period. And of course, many of them would be treated with intention to cure, but then recur at some point in time. And again, we could talk about whether this is right or wrong, but this is what we did in terms of conceptualizing, making a point that this was a neglected community of patients. And so I want to go through what the report actually said, because Larissa really did a great job kind of updating us and saying, well, we actually did accomplish a lot. But I, reviewed these slides last night, and I want to just say that, in fact, these things are still here, okay? It's still a neglected phase. There's more attention to it, and yes, it's great that we have an office that's done so much and a lot of other things, but cancer survivors are really still concerned about these things, and they are not necessarily getting their needs met. We have guidelines. Some of them are better, but you heard we have a lot of different guidelines. Nobody knows exactly what should be done. And we still have this problem that providers lack education and training, and that's across the board. So we've heard about that in the meeting. So again, from the point of view of the survivor themselves, they may be completely unaware of risk. I saw a 45-year-old man who had been treated for leukemia at age 3. He has heart failure, and he's been treated well for that, but he just went for infertility testing, and at this age found out that he was infertile after having just been married recently. So again, he had no idea. I mean, he had some idea that this could have happened to him, but it wasn't there on his agenda. So again, opportunities to intervene and do things may be missed. And again, we're not a lot better. And cancer care itself, we know, is not coordinated. So what happens when people are in the survivorship state? And again, we have more models. I think we heard a great session this morning about this, but again, we haven't moved as far. It's 12 years later, and we haven't moved as far as we would like. The final point from the report, in terms of really calling out that while cancer may not really be a chronic disease for everyone in terms of being on long-term therapy, although we do have people who are on lifelong therapy. You think about patients with CML, and others. This is really something that needs chronic monitoring and follow-up to a low, intermediate, or high-risk population. And again, that stratification I think is really important. But the idea of prevention of secondary sequelae of treatment and prevention in general for these individuals, surveillance for the cancer recurrence, surveillance for new problems, and intervention and coordination of care. These have not changed. And again, these were fundamental recommendations in the report. I think we've also been grappling with the issue of when does survivorship begin? When is the definition of this? You know, is it from the time of diagnosis, as the NCCS said when it was chartered? And again, it could be very important just to do that right from the very beginning, because the treatment decisions we make for somebody, if they already have underlying heart disease, we have to be careful about what medications we give them. If infertility is an issue, we need to take care of that as well. And so the eye is really in the beholder. Patients don't like this word, we don't have to use it, but whatever, we have to provide some kind of chronic education and ongoing care for patients. And again, I don't think focusing on the label really helps us at this point in time. So I mentioned the other day that the Cancer Institute funded many rehabilitation programs, and Suzanne Millette, who was at the University of Virginia in Richmond, was one of my early mentors. She was a medical oncologist who was running rehabilitation programs within there, and this disappeared from the landscape, as I mentioned. And again, I really saw that what I was doing in terms of trying to improve the quality of life of patients with cancer, which is where my research had been in the 1980s, was where rehabilitation should be. And so I think we need to think about this, and physicians treating patients with cancer need to think about the possibilities of anticipating the kinds of sequelae of treatment, and again, initiate preventive interventions. And again, why is cancer different from other chronic diseases? It's very complex. We have many, many kinds of treatments that we use that are overlapping. Often primary treatment may take a year or more for many patients. It's very toxic. Our therapeutic ratios in terms of the lethality of the drugs that we give, or even the radiation treatments, there's a close margin there for patients. So it is a very, very high-risk kind of treatment. It's expensive, and again, often poorly coordinated during treatment. So again, what happens afterwards? And as we've always heard, again, in these discussions, still today, cancer treatment is still occurring in isolation from the primary care physician, which I think is something that we can easily fix electronically in the record, and by asking the patient, who is your primary care physician? So again, many specialists, many different venues, really hard to get those records. That's why everybody's complaining about putting a survivorship care plan together. If somebody's not being treated in an individual institution, it becomes very difficult. And again, concerns that we don't have enough data about what we need to be doing for people. And again, there is this bit of a tension of, well, are you really just saying, well, I'm going to be the next 12 to 18 months seeing if the person who had a high-grade lymphoma recurs, or a sarcoma, do I really start survivorship care then? Or, do I start it with my breast cancer patients when they're going on endocrine therapy and they've finished their primary treatment and it's a transition, and I can talk about wellness and adhering to their medications. So again, when do you put health promotion and disease prevention into the mix when you're not quite sure if somebody's been cured yet? And again, these are all strategies that have been proposed, but again, none of them have actually been implemented even in the acute care setting. So this is, again, an old slide when I would talk about the report. Why do we need a survivorship care plan? And again, I think we've gotten too hung up on how complicated these documents actually can be. As Gina and Mark showed, it can be pretty simple, but it is really important to know, did they have radiation? Did they get radiation to the chest? Did they get a drug that could cause leukemia in the future? I mean, you need to know what the exposures were if you're actually going to provide this kind of follow-up care. So we need some kind of summary. And again, the idea is to be able to communicate to the survivor in some language that they can understand. What do they need to look out for? And what is anyone else who's going to be seeing them downstream? The dentist, their primary care physician, anyone that they might, with their traveling, what kind of history did they have? So again, in the health promotion, disease prevention piece of this, that's a positive thing. That's a message that we can give to people. This is something you can do. You may not have control over the cancer, but these are proven things that we know we can help prevent other chronic conditions. So this is Ed Wagner's model, and I think, again, we were thinking of the chronic care model when we wrote that 2005 report. And again, the Survivorship Care Plan was just a vehicle to have those informed communications between the patient and the care team. And again, looking at the health system and the community, if we have all of these things in line, again, bringing in self-management, decision support, clinical information, we have many more electronic tools than we had at that time. So we're in better shape to be able to do this. So what's happened between 2005 and the present? So cancer treatments became even more complex than they were at that time. We have so many targeted therapies. We have complicated regimens that patients are on therapy for a long time. The cost of care has increased exponentially, and again, the term financial toxicity didn't exist. It really wasn't in our vocabulary at the time we did that report, but is clearly front and center on everything we do, and that is one of the ongoing burdens for people who have been treated for cancer. A good thing, the ACA expanded access to healthcare through insurance and really removing the lifetime caps on coverage, because our cancer patients often met that $1 million cap very, very easily if they had even that generous an insurance plan. And pre-existing conditions could no longer be excluded. And again, this is all being threatened, so we're very, very concerned about it. But one of the health economists who was on our 2005 IOM panel, she was a BRCA carrier, and this was her very big concern about pre-existing conditions for patients. So again, and the extension to age 26 was really important for the younger individuals. But coordination of care is even more challenging, okay, because of this kind of complexity and because of the challenges of whether people have insurance coverage or whether they're going to lose it. I mean, so many people are worried about this right now. So I think while we've had some good things that have happened, we have to be vigorous in trying to defend some of these gains that have been made. So the IOM report that's been alluded to and we haven't really talked about, but Ron has really been a wonderful champion for this with the OCM, we really focused on all of these things. And fortunately, I had Mary McCabe and Larissa Nekludov, who actually were on that panel. So we had survivorship very well represented. And again, the idea of how do we deliver high quality care to patients. And again, this was our conceptual framework for the model, which again, I want to really speak to the importance of patient-centered care along the continuum of care. The patient is the center of all of our activities as we deliver cancer care, and we try to improve the cancer care system. So this was our first goal from that report, and as Ron kind of alluded to, and I don't know that Larissa really meant that we didn't deliberate on our recommendations and the 13 points, but I'll tell you what, you know, we really had, this is a blueprint for the future, something that 10 years from now our goals would be achieved. And this was our first goal, that the cancer care team should provide patients and their families with understandable information on their prognosis, their treatment benefits and harms, on palliative care integrated from the time of diagnosis, psychosocial support, and estimates of the total and out-of-pocket costs of care. So again, this was our first recommendation, our goal, and then this was a specific recommendation. The federal government and others should improve the development and dissemination of this critical information with decision aids to help patients. And again, very important if we're thinking about the long-term potential effects of treatment, that we need to train clinicians, in communication, and then the team should communicate and personalize this information to patients and collaborate to develop a care plan. And again, we can think about this care planning is really being the Uber plan above what we would think about in terms of survivorship care plan, and that CMS and others should design, implement, and evaluate innovative payment models. So this, I thought, was, you know, really a glorious recommendation, but would never be implemented in perhaps my career time. These were the things, the 13 items that Ron alluded to as being in a cancer care plan. And again, very, very fortuitously, about 9 months later, the CMS responded to this, made a recommendation that they were going to start the oncology care model. The rest is history. I think the real trick here is they have put extra money in there for practices, $160 per beneficiary, additional payments to provide this kind of high quality care, to deliver those services in a more integrated way. and again, putting this in the structured plan for how they're going to be evaluated. So this is an important first step, and I think I can't thank CMS enough for doing this, because we really have a foothold, if you will, to get some of these things done. But I want to talk about some of the things that came out in the meeting in the last day and a half. And really, we need to do more. We need an adequately trained workforce and a focus on the needs of caregivers, because the complexity of initial treatment as well as the ongoing needs of survivors have been underestimated, and we need to have these two things in place to be able to accomplish those goals of better care. We need to collect better data on diverse populations with cancer who are not represented in our research study. We heard a lot about research. We heard a lot about programs that have been funded and demonstration projects, but many of these are not serving diverse populations, and we have no idea. It was wonderful to hear the presentation about rural America, because I think there are many people who have even more complex needs than we estimate. We need to integrate evidence-based psychosocial services into standard care and eliminate services for which no evidence exists. I really resonated with what Mark said. The key thing in my survivorship program has been screening for depression and having a mental health professional see the patient before I see them, because I see people who have had excellent medical care in my institution or in the community, but they have never had their psychosocial needs met. And again, you heard from our panel yesterday, we know how to do this. There's stepped care available. I just read the New York Times today, where in England, in the UK, they have now a universal program for the healthy mind, where they've taken away the stigma of mental health care. People can call in if they've got a mental health concern. They get screened with a communication for an hour, a structured consultation on the phone, and get funneled into the kind of care we need. We need to fill in this gap, especially for our cancer survivors. And again, we need to develop and implement quality measures for survivorship care. If you can't measure it, you can't evaluate it, and I think that really needs to be the immediate challenge for many of the people working in the field, because many of you are doing things that are going to be measured and be effective, but if we don't have those outcomes and those metrics, we can't accomplish that. So I think that's my last word, except here to think about that trajectory again that I showed you at the very beginning, and these are things that we can actually do. Again, if we think about the cancer journey starting at the time of diagnosis, we need to do risk assessment and intervention at diagnosis to understand where that person is and how our treatments may affect their life as a survivor. And by really telling them that we expect them to survive, this is going to be very important for them. We need to find safer therapies. We need to give the right therapy to the right person at the right time. This is part of the precision medicine, precision oncology strategy. And again, we need to deliver survivorship healthcare, focusing on palliation, prevention, and health promotion. Thank you very much.